So I am recording now on the cloud in WebEx, and I am recording now on my YouTube recorder. So hopefully everything will work out here. I would like this big bar to go away. Let's talk real quick about a concept called fluid shifting. It's going to be really, really important for the next two semesters for you. If you already understand this, that's great. But I really, really want you to understand the concept of that water moves from areas of high concentration to areas of low concentration. This is, there's a lot of content on these slides. Like I said, a lot of this is just me talking to you on the slides. And so that when I talk again to you in lecture, it should be that you can sit back and absorb during lecture, because a lot of things are written down, but maybe I say something that strikes a chord with you. So when I talk about fluid movement, I'm usually talking about in between cells and in between blood vessels. So when we say intravascular volume, we're talking about blood volume, the amount of fluid in a blood vessel. So I want to see if I can draw on these. Yes, let me see if I can draw. When I talk about blood vessels, I'm talking about fluid in here. So when we have blood vessels, they are either full of fluid or they are dry. So a blood vessel that is full of fluid has a decent blood pressure. A blood vessel that is not full of fluid does not have a very good blood pressure. Let me see if I can undo. Let me erase all that. So let's say that your blood pressure is high. That means that your, get my little drawing thing again. Come on, let me draw. It's erasing. Cancel. I'm learning my technology. This will get better and better. But blood vessels that are full, have a high blood pressure, usually have two things. They are full of fluid, or the blood vessel is constricted around this fluid, giving you a high blood pressure. If you have a low blood pressure, it looks more like this. There's not very much fluid running through it. So very little fluid running through it. So when you have low blood pressure, you have low amounts of volume in your blood vessels. When you have high blood pressure, you usually have a high amount of fluid in your blood vessels. We would like our blood vessels to be full, but not full to bursting. And that is really our goal here. Fluid will move in and out of blood vessels. So all this stuff out here is interstitial space, or your tissues, okay? Your blood runs past all your tissues. So if your tissues are dry, blood or water should go from the blood vessels. Draw. Wants to erase. I wanted to change my color, and now it's being silly. Draw. I'm still learning to use my tools, pardon me. But blood will move from the blood vessels out to the cells, or out to the tissues. When the tissues are dry, fluid will move out. Does that make sense? If the tissues are full or swollen, let me erase all this mess. If your tissues are full of fluid, so let's put all the fluid in the tissues here. This is just a concept. I should probably make this picture a little bit bigger. But if your tissues are full of fluid, this is very wet tissues, they're all swollen and puffy, full of fluid, then that fluid will run into the blood vessels, making really just high pressure to low pressure, okay? Water moves high pressure to low pressure. So when I'm talking about water moving around, usually they move high pressure to low pressure. The other time water moves around is, so that's where, you know, they'll move from pressures. But then the other time they move around is, let's say there's a lot of thick molecules in here. So we're going to make them, these are thick molecules. We're going to call these proteins and sugars. Thick molecules. Oop. I don't know what happened there. I lost my annotation. I was in the middle of drawing a beautiful picture. So thick modules here. We're going to call these albumin, glucose, things that have a lot of weight to them. They attract water. So let me see if I can draw without getting rid of my drawing. So albumin, proteins, glucose are big, thick things that make our blood vessels thicker. That makes the fluid thicker. It's full of solutes, full of things that make the fluid thicker. Well, now if this fluid is very thick, water will be attracted from the tissues into the blood vessels. And this is how we keep fluid in our blood vessels, is by having albumin circulating around in our system. And we have a level of sugar floating around in our system. And we always have that floating around in our blood vessels to keep fluid in the blood vessels to attract. Is that why diabetics are always thirsty? Yes, 100% why diabetics are always thirsty. We will talk about that when we do DKA, because there's so many thick things running around. Their glucose, their blood is like maple syrup. And so it is attracting fluid from the tissues, and then the tissues send off signals that they're dry. So when you are super thick, you will suck fluid from your tissues into your bloodstream to dilute that thickness, to dilute out that syrup. That's just part of how fluid moves around. If you are, so we'll just I wish there was just a big eraser that I could just erase everything without moving forward a slide. If, again, you are missing a ton of thick solutes, so you have maybe some low blood sugar or you have a low albumin level, well, there's nothing to entice fluid from this area, and it just stays in the tissues. It's already thin enough, the water's not attracted to go in there, so that's kind of what makes fluid move around. The other thing, so there's thickness, there's solute, there's pressure, and then there's also sodium. Water will follow sodium around. I like the vision like a little puppy. So let's call these sodium modules. So let's say you have a lot of sodium in your blood. You have a high sodium level. If you have a high sodium level, where is water going to go? From the tissues into the blood vessels, making your blood full of fluid to dilute out that sodium. Water is attracted to sodium. If you have a low sodium level, oh my gosh. If you have a low sodium level, then you don't have very many sodiums running around in here. And you have more sodium hanging out in the tissues because there's more sodium here. Water will stay attracted to where there is more sodium, and it will all stay out here. And there is no pull into the tissues. So there's 3 different things that cause fluid to pull in and out of your bloodstream. So I just want that in the background as a concept, because what is going to happen here, so when I say tissues, I do mean intracellular and interstitial together. We're not going to differentiate for ease of purposes in between them. So let me just clarify that then. When you see intravascular, that is fluid in the blood vessel. And when you see this word interstitial or extracellular, when I say anything in the brown here is tissue. Okay, when I talk about fluid shifting, I don't differentiate. It's either in the tissues, which includes cells and the area around the cells, or it's in the bloodstream. As far as we're concerned with bodies, there's only two places for fluid to be: tissues or blood vessels. Okay? Concept there: fluid is either in your tissues or it's in your blood vessels, and things will shift around. So one more concept that I want you to have on this. Now I want it to move forward, and it won't. Come on. I will get better at this. Come on. Forward slide. Go. There we go. So low amounts of fluid in your blood pressure will give you decreased volume, and you'll get these signs and symptoms. Now, I'm not going to make you memorize these slides. These are concept slides. Don't go ahead and memorize these slides. Don't worry, we will do these concepts in all our lectures. I just want you to, if you need to go to a slide to clarify yourself there, this is a slide to help you get on the page that when we have low amounts of fluid in the blood vessels, that's when you have a decreased blood pressure. When you have high amounts of fluid in the blood vessels, you have an increased blood pressure. I just need that concept to be clear on there, and I like to put pieces with it. Again, my slides repeat themselves many, many times, so those are just more concepts. This is a hard concept for people to think about. Again, it's just a concept, but it helps you apply what you're going to see when we talk about lab values. When you have a low amount of fluid in your blood vessels, everything's more concentrated in that blood vessel. So my daughter actually helped me come up with this Kool-Aid packet idea. All right? You're going to take a packet of Kool-Aid. We're going to call that Kool-Aid, let's just call that sodium. Okay, we're going to call that, instead of being a packet of Kool-Aid, let's just call it a packet of sodium. Maybe we're doing a salt packet. You can do a packet of anything. When you put that salt packet in, that salt packet is, let's call it, I don't know, we're just going to make up a number, 100 milliequivalents of Kool-Aid. All right? I have a packet that contains 100 milliequivalents of Kool-Aid. We're going to take that 100 milliequivalents of Kool-Aid and drop it into a cup with 5 milliliters of water. Then we're going to draw a milliliter of that water out and send it to the lab. What do you think your lab values are going to show? We put 100 milliequivalents of Kool-Aid into a cup, and we pull out 1 milliliter of that cup. It's going to look like we have a ton of Kool-Aid in our bloodstream, right? Ton of Kool-Aid. We've got a huge Kool-Aid value in our lab. The lab drew this Kool-Aid value and said, oh my God, your Kool-Aid is critically high because you got too much Kool-Aid in your system. Let's put that same packet of 100 milliequivalents of Kool-Aid into a cup with 100 milliliters of water, and then pull out a milliliter of that and send it to the lab. Now the lab is reporting that you have critically low levels of Kool-Aid in your system, because what you pulled out of the cup to send to lab, what I'm showing you is that your Kool-Aid level didn't change. You've got 100 milliequivalents Kool-Aid circulating around in your system. We didn't change the level of Kool-Aid. We just changed the amount of volume. So the moral of this story, of this Kool-Aid story, is that if you get a high value on your labs, whether it's hemoglobin, potassium, any electrolyte, those high values don't mean a dang thing until your levels are equilibrated, okay? So don't treat lab values. So don't freak out about lab values. If your patient is hypovolemic, you're not going to worry about lab values yet. Your priority becomes fixing your volume status, because you can't worry. When you get lab values in a hypovolemic or a hypervolemic state, we don't really know what your true electrolyte or lab levels are. So I want to put that out there in your hopefully maybe when that helped you understand a little bit. When you get high sodium levels, they have a second question for you. What's your volume status? And the reason being is if you have high sodium levels, but you are dry, well, that's not a big concern. As soon as you get rehydrated, your sodium level will drop. So when your patient is dry or fluid overloaded, your lab values are basically meaningless until you get your patient rehydrated. So I just wanted to put that out there as a concept as well. Again, not going to be a test question on that, but I do want you, that will help you with your prioritization. A lot of people get stuck and they're like, oh my God, my potassium is really high. And you're like, but it's really not, because your patient came in with a blood pressure of 60. So if your patient's got a blood pressure of 60 and has no fluid volume, of course your lab values are going to be high. As soon as we rehydrate the patient, you see those lab values change. And it's not because we gave or took away any potassium. It's just because we put more volume in the system. So just some concepts there that if they're unclear to you, that's perfectly fine. We will go over these things when you talk about lab values. If something doesn't seem to make sense, and where we see this a lot is in trauma patients. They'll get a blood, they'll draw a hemoglobin on a trauma patient, and they're like, oh, the hemoglobin's okay. The blood level is okay. But your patient doesn't actually have any circulating blood, so it seems okay. And then we give them a ton of fluid because they got a low blood pressure because they're a trauma patient, and now all of a sudden their hemoglobin dropped. They didn't bleed, they just got rehydrated. And so a lot of times you will hear nurses say, oh, we didn't treat that lab value because it was concentrated. And you're saying, how do you know? They knew that their patient was dry. They knew all their lab values were concentrated. So just some concepts there that I think are important that get passed over, in thinking about things when they're writing lists for you. And I just wanted to make sure you had that. The reason we care about all this is for your IV fluids. What the body does is it balances out its fluid volume level in its blood vessels to have this osmolality. You don't have to memorize this number. You don't have to memorize any of these numbers. So take away, I should write on there, don't memorize. Just take this slide off, but I want you to understand why we give the fluids we give. All right? This is not a nursing job to decide. This is an order from a physician because the fluid that you pick has consequences. But it is up to us as a nurse to, if a patient is getting inappropriate fluids or fluids that are causing a problem, to call that to the physician. So what we are looking at here is we want our fluids to be the same volume, because if we are giving a patient fluid, we probably want it to stay in the blood vessels, right? This is what happens to the fluid when we put it into the body. When you stick that IV in and you put fluid in, this is what will happen. If you're giving lactated ringers or saline, it stays in the blood vessels. Okay? If you give anything other than saline or lactated ringers, it's going to cause fluid shifting. It's going to push or pull fluid in or out of your blood vessels. And yes, they will use these things for a reason. If you give someone a hypertonic or thick, so think about hypertonic as maple syrup. You're giving them something that is thick, and anything with dextrose is already a thick thing. So all of the dextrose ones are thick things. When you give them something that has dextrose or something thick in it, you've put thick fluid into your blood vessels. So I'm going to see if I can draw again. Let's do a blood vessel. Hello, Mr. Blood Vessel. And now we're going to put an IV in, and we're going to infuse something thick. So now we're putting in this thick fluid. So if we're putting thick fluid in, what's going to happen in the tissues around it? Where is fluid going to move to? We put thick fluid into the vessels. We've just infused our D5 normal saline. Water will move into the vessel, correct. We have now made this vessel thick, so water is going to pull out of the tissues and into the blood vessel. If that's what you wanted to do, then great. That's exactly what we want. Maybe you have edema, but you have a low blood pressure. That is possible because the fluid's in the wrong place. It's not in the blood vessel. So we will give fluids like this to pull fluid out of the tissues and into the blood vessel, which is where we want it to be in the first place. That's lovely. Let's talk about if we give one of, let's draw another vessel here. We're going to put another vessel here. And we're going to put in another IV. And we're going to put in this hypertonic solution, or hypotonic solution. So, yeah, hyper is skinny. So oh, well, that's a great mnemonic, too. I love when you guys add things, because if you remember it a certain way, then maybe somebody else will remember it a certain way. So, hyper is thick and will make your blood vessels thick. And hypo is thin. And so everyone's putting in their mnemonics. That's lovely. So we put a fluid in that is thin. It's almost watery. Hypotonic is almost watery. So if we're putting pure water or something very thin into our tissues, and now we're bulking up the vessels with this tissue, with that thin solution, where is our water going to go? It is going to be pushed out of the blood vessel. Come on, draw. Don't move, draw. It's going to get pushed out of the blood vessels. Oh, come on, you can do it. You can draw a little pin. There we go. And go out into the tissues. So we will use this to rehydrate tissues. But if you keep infusing this thin fluid in, it will keep pushing fluid out until you can actually cause those tissues to get overhydrated, because the longer we give that fluid, it will just keep pushing fluid out of the blood vessels into the tissues, and the tissues will get overhydrated. If we give hypertonic solution for a long time, it will keep pulling blood in. Even when the blood cells are full, it will keep pulling blood. It will keep pulling fluid from the tissues into the blood cells. So you can see that if we keep giving these fluids over a long period of time, it will keep pulling things. It'll keep pushing things. So usually we will do lactated ringers or saline, because on this, here's our lovely little blood vessel, and we put in our IV and give the isotonic solution. Now this just stays there. It doesn't push or pull at all. It just stays there and fluffs up that blood vessel, but there's nothing to attract it out or in, so it just stays right there. And that's usually what we want to do with fluid, is we want to give it and leave it in the bloodstream. We usually give fluid to get our blood pressure up, which means we want it to stay in the bloodstream. So think about these things and just kind of understand that people don't just choose a volume willy-nilly, and if you need to run and grab some fluid quickly to give to a patient, pick lactated ringers or saline or isotonic. Fluid should always be isotonic unless the patient needs to shift fluid, and that's why they are ordered by the physician. But if you see your patient starting to get dehydrated and you're giving them fluid, you're giving them D5 half, or you're giving them D5 normal saline, and they're starting to get dehydrated, you're giving this at 175 an hour, maybe it's time for a fluid change. Maybe they need to change to regular LR or regular saline, something that we can monitor for. Remember, anything other than lactated ringers or saline will cause a fluid shift, and we need to be monitoring our patients to make sure that that fluid is doing what it's supposed to be doing and staying in the blood vessels. So I'm going to leave that there for you to consume at your own. But again, not a test question. Just understand how fluids work. And I think let's move on. So I think those are the big concepts from here. If you've never heard the words crystalloids and colloids, this is just a definition. I really want you to just understand that crystalloids are IV fluids, any kind of IV fluids. All right, that have mineral salts, electrolytes, vitamins, anything you see that doesn't have anything thick in it, or just regular looking clear IV fluids are crystalloids. Colloids are specialized solutions that are usually full of some kind of cell as well. So albumin is a very, very thick, and you can tell the difference. If you've ever held albumin or a blood product, they're much thicker than an IV fluid. Crystalloids are water-soluble, colloids are not. So colloids are always hypertonic. They are always like syrup thick. When we put them into the blood vessel, they will replace the cells that are lost, but they will also pull fluid from the tissues into the bloodstream. So we will use crystalloids or colloids depending on what we want to do. So just another concept there. What the rest of these slides are, you guys know what hypovolemia and hypervolemia look like. I'm not going to test you directly on these. I just am using this as a way to introduce how I want you to study, or how I think will be a good idea to study. If you have a study technique that works for you, I am not requiring you to move to this technique. But if you've had trouble studying or trouble relating to how we use this for nursing, this might be helpful. It kind of goes along with what I showed you at the beginning of the semester, your critical thinking process. This is a critical thinking process. I just renamed things a little bit to give it a mnemonic of remit. And remit means to kind of take away symptoms or refer for judgment, which is what we do. This is what nursing does, is we take everything with a grain of salt, we judge it, we decide if it's appropriate or not, and get them what patients need. So the first step of it is the chart review, recognizing the cues, and this is what other people would call signs and symptoms. We want to recognize things that will point us to certain problems. We evaluate that problem. Does the problem just exist and we're treating it, or is this problem getting worse, or is this problem getting better? We evaluate all our problems. We know what to monitor to see if that problem is getting better. We know how to intervene, and we know how to tell our patients about it. And that is how I set up all of my slides for all of our problems. And so the first problem is just hypovolemia, and this is just showing you how I set that up. Here's what hypovolemia looks like. Here are the things that you need to recognize for hypovolemia. I try to make it a list that is 3 to 5, but you can see that, or if you remember orthostatic changes, that accompanies dizziness, change in vital signs. There are multiple things that give you orthostatic changes, but if you remember that if your patient has orthostatic changes, dry mucous membranes, and concentrated lab values, they're dry. How do we know if it's getting worse? And this is something that I do believe isn't taught. It's not recognized in the book. They don't tell you how the problem is getting worse. They just tell you a whole list of stuff, but they don't tell you what it looks like when it's getting worse. If it's getting worse, it is your blood pressure's dropping, your heart rate is going up, your urine output is going down. That means that this hypovolemia is no longer just, yeah, you're kind of dry. It's something that we need to address. And when something is a priority problem, we will usually not spend time screwing around doing more evaluation. We usually move right to treating the problem. So you'll see when we do test questions, I'll be like, look at those cues we gave you in the test question. That's a worsening problem. And that will help you with those. What do you do first? What's your first intervention? That will help you with these problems. If you have a worsening condition, you go straight to treating. Here are the things we monitor. If the problem's not worsening, we're going to keep an eye on things to make sure it doesn't get worse. And if we are treating the problem, what are we going to look at to see if they get better? I did a second table here to show you kind of like when we're monitoring key assessments. This is how I want you to learn how to think. All right, your patient's dry. We're giving you fluid, or we gave you Gatorade, we gave you electrolytes. You're dry. If you're getting better, everything should start to get better. All your key assessments should improve. If you are getting worse, then you will stay dry. Things won't improve. You can also overfix problems. We're giving you a ton of volume. We're giving you fluid to rehydrate you. You can overhydrate a person. So when you're looking at these key assessments, and I stop doing this for you as we move on, I kind of am just introducing you to how I think this works really well. But one additional thing under key assessments, rather than just memorizing a list of key assessments, which you could probably figure out, hey, I'm dry, I want to watch your blood pressure, your heart rate, and your mucous membranes. What do they look like if you're getting better? What do they look like if your treatment went like too far the other way? We can over-treat people. This happens when we give medications. How do you know if your medication is effective or if you've given too much of it or given too little of it? How do you know if your treatments are appropriate? And I would like you to start thinking things through under these key assessments. I don't do it for you on every slide, but this basically, the hypo and hypervolemia slide are ideas of the best way to use this process. See if your interventions work, see if you're just monitoring, see if you're fixing things, or see if you're just doing too much. And then here are the actual treatments that you're doing. There's usually something that is quick and you don't need an order to do as an intervention, and then there are things you need orders to do. And I try to word these out when we go through problems. There's something that will quickly do something. So on a patient that is hypovolemic and symptomatic, then you can lower their head of their bed. You can raise their legs. What is that going to do? How does that fix your problem? How does that change your blood volume status? Well, I put it there for you. It will improve your perfusion to your heart and your brain. It's a quick thing that just helps you fix your patient quickly. It won't solve the problem long term, but it's something quick. And so when you're looking at NCLEX questions, sometimes they say, what do you do first? And none of them are the treatments that you wanted, but one of is quick, because NCLEX wants you to know what can you do and what do you have to call a doc for. As soon as you call a doc, you're delaying treatment. It's going to take you a while to get what you need. So they want to make sure that you're doing something quickly for the patient. So usually when they're asking, what do you do first? It's usually, what's that quick non-invasive intervention that you can do to help your patient until you can get to a doctor? Like I said, when we do questions, we'll practice all this. But really, give them fluids. That's the treatment. That's what's going to fix it. Oxygen's not an important thing, but it can go there if you need it. It's really just fix the problem is what NCLEX is asking you to do. It wants you to know what can you do to fix the problem before you get an order from a doc, and then what's the order from the doc that you want. Those are what NCLEX is really asking you. They're not asking you in detail about it. They just want to know that you know how to safely take care of a patient. And then, of course, under treat and communicate, things that we want to tell the patient about. Usually this is where I put the causes of the problems. And like I said, as we go through these slides, this will get more and more familiar to you. If there was a cause, you teach the patient about what caused the problem so that they don't get it again. Hey, you didn't drink enough. Maybe next time you should drink a little bit more. Maybe your patient's 80 years old, and just so you know, hey, they don't really have a thirst drive. They don't feel thirst anymore. So, of course, older patients get hypovolemic a lot. You'd have to teach your patient, you know what? As you get older, you don't get thirsty anymore, so you might want to schedule yourself drinking a glass of water every hour, just so that you don't get dehydrated next time. There are things that you basically can educate your patient on depending on what caused the problem. And then it will tell you, prevention and how to keep the problem from happening again. And then I did a table, exact same information, just in a table format. You can pick what you like, okay? Just because it's on a slide doesn't mean you have to memorize it. If you're like, that is too busy, I hate that, then don't look at it again. Don't do it if it bothers you. But if you love everything in one spot, use it. Use the format. And what I do is I don't give you the tables or anything. I will let you decide whether you like the tables. But I will always give you the content in the format that you can use the tables if you want. Okay? So like I said, just getting to know me and my lecture style. Like I said, not every slide is a must study. A lot of them are reiterated. But I can tell you if something is on multiple slides, it's probably pretty dang important. You might want to get that. And I just do the same problem, the same thing again with hypervolemia, working through that. Because I think you guys know those topics, but I just want you to see how I break those up. I also do med cards for you, okay? Usually if they are important medications that you're going to have to study for NCLEX or study for, for exams, If that med is called out on a med card, you might get a question on it. So if I call out diuretics, then hey, you probably should know. I'm hoping you already know about diuretics, but I just put it on a card for you. If you have your own diuretics cards and you like them, maybe just add something or get rid of it. They're here for you to use as you need to. But this basically means that, she called out diuretics on a card. That's something we probably need to be comfortable with. So, it doesn't mean I'm going to ask you, select all that apply, the patient education for diuretics. It just means that I need you to know something about diuretics. So that is just kind of a little quick review of that slide bank.